Good evening, students. We are back with the second module of the basic principles of surgery. This is enumerate or describe the factors affecting metabolic response to injury. Right. So there are 10 to 11 factors that affect the metabolic response to injury. Earlier we learned what were the metabolic changes or metabolic responses to injury. Now we'll learn the factors. This again could be a long note for you for both PGs and UGs, that is undergraduate and postgraduates. So here if they ask you to enumerate, and if this module of this question is a part of a larger question, then you only have to enumerate these 10 or 11 factors. If they ask you, if it is asked in the question paper to describe, then you have to describe the effect of each on the metabolic response. First is age, second is nutrition and diet, third is hypovolemia, fourth is hypothermia, fifth is tissue under perfusion, sixth is tissue edema, seventh starvation, eighth anesthesia choice and surgical approach, both are surgical factors, 10th immobility, which may also be a surgical or post surgical factor, and 11th is intra and post operative thermoregulation. It is an operative and anesthetic factor both. So first the age, right? Age, the onset to response to injury is delayed and weakened in the elderly and the infants, right? So at the extremes of age, that is the elderly and the infants, the response to injury is delayed. Why this is delayed? This is delayed because of depleted energy stores in the elderly, which make them prone to delayed onset and prolonged pro-inflammatory phase. So the inflammatory phase, it is delayed in its onset, and when it starts, it lasts for a longer time because it is basically weakened. So whenever a process is weak, so it requires a longer time to cause an effect. Okay. So this is the reason why the elderly have a delayed onset and a longer pro-inflammatory phase. Both the extremes of age, that is the elderly and infants, have a delayed onset and a weakened response. Children, on the other hand, that is the pediatric group, have an excellent response to inflammation. Okay, that is because they are in the growth phase. Some may be in the growth spurt. That is why their responses are accurate. Their responses are fast, and the metabolisms which occur are at their peak. Right. Third reason is that protein and lipid catabolism leads to severe involvement of multiple organs. That is more, and which makes them more prone for multi-organ dysfunction syndrome. As we have learned that liver has a significant role, and kidneys, they have a significant role, renal tissue, renal parenchyma. So all these tissues, when they take part in catabolism, protein and lipid catabolism, these solid organs are also made up of proteins. That is why more protein and lipid catabolism may lead to severe involvement of multiple organs. Next is nutrition and diet. Malnutrition is associated with delayed and inadequate response to injury. The reason is obvious, because there are depleted stores of proteins, and proteins are the raw materials for immunoglobulins and the immune system itself. That is why malnutrition is associated with delayed and inadequate response. Now, absence of nutritional supplementation and inadequate replacement of calories. This sentence, that is inadequate replacement of calories, is more relevant in a post-operative or in a sepsis phase, where as surgeons or as attending physicians, we are required to supplement adequate calories so that the body can fight, or the immune system can have a fighting chance against sepsis or against the injury. So early return to enteral diet, that is diet where the food or the calories are given through the intestines, okay, through the gut. Okay, this will stimulate the gut immune system. The gut also has immune system, that is mucosa associated lymphoid tissue, that is associated, and that also helps in immunological responses. Now, if there is absence of enteral diet, what we do, we give total parenteral nutrition. If the patient, or in cases where prolonged NBM is a requirement because of anastomosis or because of peritonitis, The patients may have had perforations. Mostly we keep them nil by mouth for up to 7 days, after which we start liquids. If the patients have attained or gained bowel motility, if the bowel sounds are present, then early enteral nutrition is preferred. If there are any indications even in intra-op that post-operative this patient might be having a longer nil by mouth period or longer fasting period, then total parenteral nutrition is preferred. Basically, we prefer early return to enteral diet, but if it is not possible, then total parenteral nutrition is used. Now, total parenteral nutrition can itself be a 5-mark note for the undergraduates, and this the solution which is prepared has calculated amounts of electrolytes, proteins, lipids, and carbohydrates. So you have to calculate the nutrition requirement of each patient and decide how many bags of TPN you use in a day. Now the third is hypovolemia. Now this is a little diagram. Persistent hemorrhage and volume loss causes the stimulation of neuroendocrine pathway, which stimulates the hypothalamus. Now hypothalamus releases adrenaline and noradrenaline, antidiuretic hormone, and adrenocorticotropic hormone. As we have learnt earlier, that adrenaline is the main hormone in the flow phase, for the flow phase, and ACTH gives rise to cortisol, which is the main hormone in the ebb phase. Right? Antidiuretic hormone causes water retention, which in turn is for correcting hypovolemia. Then adrenaline and noradrenaline, they are main hormones of the flow phase. They stimulate catabolism, which in turn help in the metabolic responses or metabolic changes during the injury. So fourth is hypothermia. Hypothermia, it induces catabolism, which in turn causes increased BMR, that is increased basal metabolic rate, and there is an attempt to increase the body temperature itself. Now, hyperthermia is only caused by release of energy, which is through catabolism. That is, again, proteins are used for release of energy. That is, they release 9 kilocalories per gram of protein. That also is an exothermic reaction which releases heat. So proteins again are important during the injury phase. Second, hypothermia also causes stimulation of the cardiac pathways and causes arrhythmias. It also causes it increases the viscosity of the blood. That is, the blood gets thicker. And it may stimulate cold agglutinins, causing microemboli. Third, again, increased viscosity. It may also hinder blood supply to the organs and may cause ischemia, that is cold type of ischemia, and delay immune factors from reaching the site of the injury. This also causes tissue underperfusion. Both hypovolemia and hypothermia cause tissue underperfusion. Right. So next, sixth, that is tissue edema. What are the causes of tissue edema? Systemic inflammation, inflammatory mediators which are leaking into the site of injury, and electrolyte imbalance. Right. What does it result in? It results in poor oxygenation and delayed healing and recovery. Why is there poor oxygenation and delayed healing and recovery? Now, when there is systemic inflammation, right, systemic inflammation and electrolyte imbalance and inflammatory mediators are causing loss of fluid or plasma into the surroundings or into the extravascular space. What happens is the volume decreases. As volume decreases, then again this causes hypovolemia. Hypovolemia may cause hypothermia. Hypothermia causes again increased viscosity, which causes tissue underperfusion and poor oxygenation. This may also cause delayed healing and recovery, because this again increased viscosity and tissue underperfusion causes delay in the transport of the immune factors to the site of injury, and which causes delayed healing and delayed recovery. Seventh aspect is starvation. Again, it leads to seventh point is starvation, leads to skeletal muscle loss and depletion of fat stores. Therefore, early oral intake is advised. As I mentioned earlier, early enteral nutrition is preferred for this reason too. Now there are some cases in which post-operatively patients require immobility, for example in orthopedic cases or laparotomies. So there is immobility. Immobility causes muscle wasting, which causes loss of skeletal muscle and later on smooth muscle also. Hence early mobilization is encouraged, and prolonged immobility may also cause deep venous thrombosis, which can aggravate the formation of microemboli or pulmonary embolism in patients who are going prolonged inflammatory phase. Ninth, anesthesia. Anesthesia as a factor, regional and local regional anesthesia, it causes less protein breakdown as compared to the general anesthesia. Now general anesthesia causes a systemic effect, and that leads to increased protein catabolism, whereas regional or local regional anesthesia has a smaller effect on the systemic or the physiology of the body and causes a localized effect. So regional, local regional, that is peripheral nerve blocks or spinal anesthesia, is always better than general anesthesia. But of course, when in cases where general anesthesia is required, general anesthesia should be given or preferred. 10th is the surgical approach. Again, minimal stress, minimal injury causes minimal response and early recovery. Minimal invasive approach causes less stress to the physiology and prevents the aggravated immune response post-operatively. So this is what we go for. Minimal invasive, wherever there are cases where minimal invasive approach is possible. Of course, there are some contraindications, but there are a lot of indications, and we prefer minimal invasive in almost all the surgeries, all the procedures. Be it laparoscopy, be it a keyhole surgery, be it small incisions, we always prefer minimally invasive approach. Minimal invasive doesn't mean that we always use a laparoscopic technique or ports. We may use a smaller incision for an open appendectomy. We may handle the tissues gently so as to cause less trauma to the tissues itself, because post-operatively those tissues which have undergone trauma or where we have used cautery a lot, they release latent heat. Fat absorbs that heat from the cautery, it releases it later on, that is called latent heat, and causes formation of seroma. Again, muscles, if we do not handle the muscles gently, those muscles are damaged during surgery, and after the surgery, post-operatively, even if we suture them, even if we do some kind of repair to the fibers, there will be breakdown of the proteins and may cause a prolonged post-operative recovery phase. The last is intra and post-operative thermoregulation. As I said, regulation of the temperature of the body temperature, core body temperature, is important. That is why we saw how hypothermia affects our immune system, affects our cardiac system. Now normal body temperature is between 37.6 degrees centigrade to 98.4 degrees Fahrenheit. This temperature is, why is this temperature preferred by the body? Because it is ideal for physiological function. It is ideal for these three things: enzymatic reactions, hormonal release and action, stability of protein structures. It is the pH of the blood is also maintained in between this temperature, in between at this temperature. So all the reactions, releases of the hormones and stability of protein structure, all these functions require an ideal body temperature of 37.6 degrees centigrade or 98.4 degrees Fahrenheit. The temperature may vary from 37 degrees to 37.8 degrees centigrade or 36.8 degrees centigrade to 37.8 degrees centigrade. That is 98 degrees Fahrenheit to 98.4 degrees Fahrenheit. Maybe also 97.8 degrees Fahrenheit. There are attempts made to maintain this temperature, and it goes a long way in early recovery after surgery. Right. So thermoregulation is also one of the steps for a process which is known as early recovery after surgery, that is the ERAS protocol. These protocols are up and coming and are part of recent developments in surgical protocols, which help in the early recovery of the patients post surgery. Right. So these were the factors which affect the metabolic responses to injury. We'll go through them again. Just enumeration. First is age, second nutrition and diet, third is hypovolemia, fourth is hypothermia, fifth is tissue under perfusion, sixth is tissue edema, seventh is starvation, eighth and ninth are surgical factors, that is anesthesia choice and surgical approach, 11th is also surgical factor, that is intra and post operative thermoregulation. 10th is immobility, which is also a surgical factor, right? So I hope this was a useful lecture. I am trying to touch on the modules which are being asked in the question papers in the form of long notes or short notes or a part of a longer question. So these are the questions which are being framed by the competency based medical education board, that is the NMC board. Hope this was useful. Kindly like, share and subscribe, and if you have any doubts, kindly share with me in the comment section. Or if you want a better presentation, if you want something more out of these lectures, please let me know. We'll also be touching the subject of objective structured clinical examinations, OSCE. Usually the OSCE, that is objective structured clinical examination, these are a part of the Western education system, medical education system. We are trying to bring it here so as to objectively assess candidates ability to to diagnose, treat and interpret the clinical labs of a patient. So we'll be touching upon that as soon as I finish this chapter. Any objective structured clinical examination questions will be discussed. Perhaps not many, we can come up with 2 to 3. So if you want anything more, if you want anything else, kindly let me know through the comment section, and please like, share and subscribe, and click the bell icon button so that you can get the notification for the lectures as and when they are uploaded. Thank you so much.